out for help. Where is he? Which way did he go?
One of London's biggest hospital trusts.
He's having a heart attack, but we'll get him in straight away and we'll get him sorted out.
Okay, on three. 1, 2, 3.
Treating more than 20,000 people every week.
Flying over the enemy lines.
This is a place with some of the best specialists in the world.
I'm amazed he's alive. He had 2 blocked arteries.
Where lives are transformed.
Oh, thank you so much.
But it's under intense pressure.
We have a financial deficit of 41 million.
With growing patient numbers.
We are full. We're always full.
How long has he been here?
13 hours and 46 minutes. I don't think that's best patient care.
And higher expectations.
There can't be nothing in this day and age.
I want to look after him.
First ambulance is on the ramp.
At a time when the NHS has never been under more scrutiny.
We're declaring a major incident at the St Mary's site.
If this was my sister or a friend or anyone, this wouldn't be good enough.
Week by week, we reveal the complex decisions the staff must make.
Anybody else who hasn't gone knife to skin, they need to be sent home.
About who to care for next.
Do you reach a point where you say enough is enough?
Yes, the family may not like that, but we are stopping, and this is where it ends.
Emergency coming 5 minutes by a London ambulance service.
So what do we know? So there's period arrest, 50, high potency of bread and cardiology.
56-year-old Edward, called about 2 o'clock, said he had central chest pain. He was in peri-arrest, bradycardic, around sort of 30 to 50.
56-year-old city worker Eddie is suffering a major heart attack.
Oh, hello. All right, Edward, you're in hospital.
After calling 999, Eddie collapsed at home alone. His heart is severely unstable and could stop at any time.
It's all right, we've got some extra pin, please. Quick. What do you need? Some pin. 15, 20, blood pressure 125.
What's the last heart rate?
It's 35.
Okay, perfect.
Yeah, that springs in.
Hammersmith is one of the UK's foremost heart attack centres, or HACs. Eddie will receive acute treatment only available in specialist hospitals.
My facts, please.
The HACs are like a specialised A&E just for the heart.
1, 2, 3.
London Ambulance bring us more and more patients, so probably double what we would have seen 5 years ago when we first started. Anna, have you got an ECG? Where's the ECG? Oh dear, the ECG is showing that he's having a big heart attack. So the team is going to intubate because he's so restless. He's got no forward output really. Next stage, which is to get into his arteries and take a picture, find a blockage, fix the blockage. It's just making sure that he doesn't have a cardiac arrest before we get to that point. I'll take that. Pressure line on, please. The faster you are, the more muscle you save. And it's important when someone's really sick to get that artery open as fast as you can. So we've got to get beyond this tricky leg.
A catheter wire is inserted through Eddie's groin into his heart. Balloons and small mesh tubes called stents will then unblock his arteries, a procedure called angioplasty.
It's got to be a big right.
It must be a huge right. OK, we're in now. Yeah, there's a huge, great big clot that's just blown downstream. We'll see if we can't suck it out. OK.
Is he stable now, or is time still very crucial?
No, I wouldn't call him stable. He's on blobs of adrenaline. So let's just see if we've got a clot here. I don't think there's any big clot there. We're going to go back in again. We need to get rid of any clot that's sitting in this line. No point in taking the clot out of the coronary artery and then blowing it into his brain. That would be bad, wouldn't it? So, now that may have trapped something because that's not coming back. It's opened up. This man had, I'm amazed he's alive, he had 2 blocked arteries. So 40% of patients have 2 ruptured clots, but not 2 ruptured clots causing complete blockages, that's to say. OK, good.
The Heart Attack Centre is one of 7 set up in London within the last 10 years to consolidate specialist skills and resources.
He decided he wanted to live.
Since they were established, survival rates in the capital for the most serious heart attacks have doubled.
OK, let's see what we have. So this is a nice story, yes? Potentially.
I'm very clear that today he was dead if he hadn't ended up with us and had gone to a smaller hospital where they didn't have a cath lab. Had he had a cardiac arrest in an A&E department without a cath lab facility, he would never have stabilised to come over to us to open up his arteries. There's no debate about it. He would be dead.
And where are you off to now?
I'm into the next lab, so we've just started another hot case, not quite as hot as him. It's a gentleman who's in his 80s who's presented with a heart attack.
Over the past decade, there's been a move to centralise NHS services in order to offer specialised care to more people in fewer, bigger hospitals. Charing Cross Hospital is the Trust's specialist centre for neurosurgery and the treatment of brain tumours.
I'm off in to see my oncologist. She's asked me to come in quite urgently just to have a chat about my recent MRI scan.
28-year-old Ben had a brain tumour removed 4 years ago.
I've been here a lot because this is where I was operated on to have my brain tumour taken out, and then also that to have my follow-up radiotherapy and chemo.
Since his operation, he's been monitored by consultant clinical oncologist Alison Faulkner.
He's been having scans every 6 months since he finished treatment. Over the last year, there's been a progressive change in his scans.
Dr. Faulkner's called me in, but I don't think it's an official appointment. She just said to come in for 11:30.
We've got the grade 3 brain tumours, which Ben has. With these tumours, half the patients have died in 5 years. And it's 4 years since surgery.
Hello. Hi, Ben.
Hi, how are you?
Good.
Nice to meet you. Oh, so I've heard your name a lot.
Kevin O'Neill.
Yeah.
Did we meet before, was it?
I don't think I've ever actually met you. I just always hear Kevin O'Neill.
Do you?
I think you're famous, basically.
So we've been discussing you, now we're a big team, so we work all together.
OK.
So how have you been? Have you been
I've been fine, yeah. I've had absolutely no symptoms from my brain.
No seizures?
No seizures since the op.
There's always a chance that things could change.
Yeah, which I've always been aware of, yeah.
I think if you look back, you can see a little rim that looks like maybe a residual bit of tumour that looks like it's been very well behaved. But in the last scan, it just part of it looks a little bit bigger. That would warrant us going in to remove that bit that's growing and potentially threatening you. So.
OK, so you're saying that you feel I should have another operation?
Well, we all feel that, you know, that there's a risk of leaving you alone. And the risk of treating you is less than the risk of leaving you alone.
From my understanding, the tumour that I have had, blah, 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 it was slow growing.
Relative to the fast ones, unfortunately, there's always a spectrum. So there's barely growing, which are what we call benign, 1, 2. The grade 3, which is what you had, means that you can't just sit and watch it and, you know, observe it lifelong.
Okay.
Has to come out, have the chemotherapy, have the radiotherapy, as you did. Yeah. And the grade 4 are the much more aggressive ones.
In terms of timings, what are your thoughts then on when would it need to?
Probably in the next few weeks, 2 or 3 weeks, we'd need to set it up. And have you got plans?
Well, yeah, I've always got plans. I'm really busy, but we'd have to work around those.
No, it's not going to be tomorrow.
And so
we've seen it grow. There's no point just sitting on it and watching it. We need to do something about it. Does that make sense?
Yeah, it's making sense. It's just a pain in the ass, basically.
It's a tricky balance.
Thanks very much. It's just a lot of stress. It's just annoying, isn't it? It's just...
It is annoying.
Yeah, it's annoying. It's just...
It's nothing to what I said when I saw the email. It really isn't fair.
No, it's not fair, but it's happening, so get on with it, I guess.
All right, so...
Yeah. Great.
Why don't you get out into the sunshine?
Yeah, exactly. Oh, it's fine. OK.
All right.
Yeah, thank you very much.
Oh.
I know, what the hell? It was going to happen at some point, I think. Oh. Thank you.
Right.
Yep.
You're not going to take care. See you soon.
Oh, thank you.
Was it always going to come back?
No. We always hope. There are patients whose tumours don't come back. He's been the unlucky one.
So this is Ben's story, basically. So he had a tumour way back in 2012. This is my colleague who did a very good resection and got a lot of this out. You can see a big resection cavity here, but over the last few years, there's been something that's been growing anteriorly. If we give it enough time to regrow, it can transform into something higher grade that will threaten him. It's very, very frustrating treating brain tumour patients like Ben, where they've had good surgery and, his tumours come back. The biggest problem with brain tumours is they have such poor survival rates. Many of them are very aggressive. For that reason, cause the greatest reduction of life expectancy compared to any other cancer, because they can affect any one of us at any age. Most of them are fatal, and under the age of 40, they're the greatest cancer killer. You want to solve this problem, and you want to make things better. That's what drives us on to try and research and develop and design new technologies, new treatments.
Kevin and his team are at the forefront of using new technology to understand more about brain tumours like Ben's.
I didn't know exactly how my story would pan out, but I had a grade 3 brain tumour, which had been treated, but there is the history that it does come back. But the thing is, I've just got on with my life, and I've enjoyed things, and I've been, living my life and getting on with it, and then it has happened, and now I just need to do it again.
Any change from this morning here?
It's 24 hours since Eddie arrived at the hack, suffering a major heart attack.
This came as quite a surprise. I would have expected there to be a feeling of panic and something like that. And for some reason, it was like, I just hope that they get here with that ambulance quickly. But if not, then this could be it. And that's all I felt. I hadn't really thought about it that hard until then. So it's quite heavy. But I'm here.
He's done pretty well, actually. He's come off the ventilator. He's come off all the drugs that were supporting the heart yesterday. He said for the extreme types of heart attacks that we see, that is a speedy recovery. And hopefully, he'll be back at work within a few weeks. Hello, sir.
Hi.
Right, how are you feeling compared to this morning? Does anything not make sense to you? Because you've been through a lot in the last 24 hours.
No.
It has been literally 24 hours this time yesterday.
Yes, indeed. No, people have explained it very well.
OK. Your heart tracings are good, your monitoring, your blood pressure and everything's been good. So I think we can literally unhook you from all of this, make the next step and get you to the ward. And you'll find as days go by, the heart gets stronger and stronger, and that should make you feel better.
Yeah.
Cool. OK. Great. Bye-bye.
As a frontline service for the heart, the hack is incredibly successful. London is pretty well served. The rest of the country is following suit. These heart attack centres mean that there's a concentration of skills, a concentration of staff. These patients stay in the hospital for less days, and therefore not only does their life get saved, it's also cost effective.
Okay, sir. Lock the door now.
Every division in the Trust must make significant cost savings to hit efficiency targets set by the government.
Morning.
It's the job of General Manager Steve Hart to oversee the Trust's cost-saving plan for their cardiac services, including the hack.
Firstly, sort of good news story for the team. So last year, 16-17, challenged to deliver a £2.3 million cost improvement programme. We actually achieved £2.6 million, so surpassed what we were expected to do. What that doesn't mean is that 17-18 is going to get any easier, unfortunately. So last year, our challenge was £2.3 million. This year, we've got a new challenge of £3 million. The plan is basically for us to either deliver more activity to a higher quality for the same money, or to deliver the same activity to a better quality for less money. I'm going to go through the plans now and sort of let's have the honest discussion around when are these likely to start. Be mindful of the fact that at some stage we may need to close beds unless we expand the service.
Every year we're asked to make more and more savings, and it gets to a point where actually there is no more meat on the bone. What about 7-day working then? Where's that rolling out?
So I think 7-day working is getting discussed as part of the chest pain pathway discussions. I'm hoping we don't need to do it, and I'm conscious that we will be calling on the same group of staff that have already said we don't really like working Saturdays and Sundays.
7-day working in principle is an excellent idea. It doesn't matter what day or time you're admitted, you should get the same treatment. However, we cannot implement something when we don't have the infrastructure to do it.
Is there a demand for a 6th cath lab to support growth in private patient activity?
I'd just like it to be minuted that I am really, really nervous about this 6th cath lab that seems to be rolling on. It is impossible to have more cath labs than we have CCU beds.
And it
cannot happen.
So the minute I think this is the bed discussion is very much a pipeline discussion. What you need to do is see it in the business case, which is what I intend to enable you to see. Heart valves is...
Primary in 8 minutes. I've got a primary call coming in with a DCS at 3. It's going to, each year's about 5 minutes.
It is difficult, and it's continuing sort of tension on a day-to-day basis. What is important from my perspective is the quality of care delivered to our patients, and our patient safety isn't compromised in any way as a consequence of any of the cost improvement proposals.
As a specialist centre, in addition to treating heart attacks, Hammersmith's cardiologists deal with rare and complex heart conditions.
Sharp scratch.
I was really, really healthy, like at the peak of my health. I was really into the gym and like fitness and everything.
We might need to keep it in because you're having the procedure.
23-year-old teacher Rosa has a life-threatening infection on the mitral valve of her heart called endocarditis.
Great, thank you.
All right, that's you done.
Right. Hello. Plan today is echo before lunch. Scan this afternoon. She's got an infected heart valve, and that's called endocarditis. It's the last thing you want to see in a young person. It carries a high mortality, anywhere between 20 to 40%.
Though Rosa appears well, infected tissue from her heart is breaking off and causing complications in her brain.
I was just like sending a text message, and then I just suddenly couldn't type with my thumb, and I was like, this is weird. And then the next day that happened again about 5 times, and then the last few times it spread to my face, and I like couldn't move the left side of my face, so I couldn't smile. They called it like mini strokes. It's so weird to just sit here and feel completely normal and have major problems in your brain and in my heart.
They said we need to speak to you, but you know, not here.
So we knew.
We knew.
We knew there was something very serious.
Yeah. In fact, they phoned us, didn't they? They asked us to come in. In fact. Yeah. All right, love.
So I can text you when I'm back.
Yeah. All right, sweetheart. Well, I'll make sure that I'm back. Okay.
Takes you right back to when she was born somehow. You sort of go back into being needed as a parent, whereas we sort of got used to not really being needed.
No, you just have this horrible feeling in the pit of your stomach. that you can't shift, you know, and it'll be there until they tell us that everything's okay, basically.
I could see the fear in her parents' eyes, and I could understand that because, you know, I'm a parent myself. I have a young daughter, and isn't it every parent's worst nightmare? This echoes from Friday afternoon when I saw her in Charing Cross.
There's a big blob. Any leak?
Yeah, it is leaking.
Oh, yeah.
Every Wednesday, senior cardiologists and heart surgeons come together to discuss their most complex cases.
Looking to operate as early as possible, I'd have thought to...
That's what we were thinking on Friday, so that's why we had so much discussions with the neurology team, the stroke team, and neuroradiology. The valve needs surgery, and she needs an operation. So it's one of the most challenging things we treat because the timing of surgery is crucial. If you don't get the timing of surgery right, the patient will die.
I saw her on Saturday. I explained that we don't know either the risk of spontaneous bleed or going on bypass. And before talking to her, I spoken to the neuroradiologist who actually said there is a very high risk of spontaneous bleed. So personally, I would wait longer.
Yeah.
They did say that they didn't think it would preclude putting someone on bypass. They have written that.
We're all strong-minded individuals, and we don't always agree. But usually we can hammer it out.
There is a reason to just wait and not rush. So I think you should really...
I think you can say that with confidence, because if it is more than 10 millimetres, the risk is always.
Is the neuroradiology MDT in Charing Cross?
Yeah. Quarter to 12. I can find out where it is
Today,
for you. Yeah.
it'd be good if I could go down, wouldn't it?
OK, fine, so we got a plan. Great. Right, who's next?
There's no clear right or wrong here, and you have to go on clinical judgment, this grey area in medicine. But at the end of the day, somebody has to make a decision.
It hasn't really hit home yet, but I know that tomorrow it's like surgery time.
28-year-old Ben is at the neurosurgery centre in Charing Cross for his brain tumour operation.
When this first happened to me, I was 24. I moved down here to train in musical theatre, which I'd worked in until this happened 4 years ago. Last time, I was having visual problems, dizzy spells, a couple of seizures, which I didn't realise were seizures, basically blurred vision. So I was rushed to A&E and they found the mass from a MRI scan. Then it was found to be grade 3. I lost my left peripheral vision. It was all pretty horrific. Giving up dancing and going to dancing auditions was hard because that was my career path. And I think I went through a sort of grieving process. And now that it's happening again, it's all a bit... It's like going back to 4 years ago, like history repeating. It's like bringing everything back.
To prepare for the operation, the team creates a 3D map of Ben's brain.
Will this be okay with these things? Yeah. That's what things are okay, fine. Yeah.
This will help Kevin pinpoint Ben's tumour during the surgery.
These days, as opposed to these previous surgeries 4 years ago, we now have more tools in the box. So we now have quite useful intraoperative imaging, which tells us where things are, despite things moving around. But we're also developing new tools.
Ben has consented for his operation to be part of a pioneering research programme, which aims to change the way cancer is diagnosed and treated.
Do you need sort of people to sort of, guinea pig this?
We don't want anybody to be a guinea pig. None of us wants to be a guinea pig, but I think we are now starting to make advances. With innovations, it's going to open up a whole new world of research and potential treatment options for these patients.
It's literally signing your life away, isn't it? No.
Good. All right, we'll see you soon.
Oh, OK, yeah. Thank you very much. Hello.
How are you doing then?
Yeah.
I've had a little bit of a shave there. OK. Did you do that, or did we do
No,
that?
I didn't do that.
Oh, okay. Okay. Well, look, you happy about tomorrow?
Tomorrow, yes.
So what we want to do is try and get you back to the point where you've got very little or no discernible tumour on the imaging.
My main concern is my visual fields, and I know you can't promise that they won't be affected.
There is a small chance that that could be affected. How are your visual fields?
So I've got no left peripheral from the last operation.
Yeah.
And a tiny bit hindered in the right.
Look me straight in the left eye
Yeah.
and just tell me when you can see my finger coming in. I'll kind of do the same. Can you see it coming in? Tell me.
Yeah, now.
Now, okay. I can see this way out here. You can't see it until we get to the midline. You've got some deficit up there, but it's mainly the lower quadrant, isn't it, on that left?
Yeah.
Right.
So
we can't guarantee. I mean, the vicinity that it's in is close to where the connections from the eyeball to where the brain perceives vision. Those radiations, it's been, they're going around that and been stretched by that, and they have been interfered with. Obviously, every surgery we do has a certain risk to it.
I wish they'd do the surgery sooner, because I'm just sat here thinking at any point some of this infection could just come off again and cause another aneurysm. What if an aneurysm happens in my brain and I'll just die?
23-year-old Rosa needs an operation to remove infected tissue from her heart valve. Due to complications in her brain, the team must first decide if it's safe to go ahead.
Obviously, there is a risk of stroke for Rosa having surgery. We're not risk adverse. We are, but the right decision about timing is fundamental.
I went down to the neuro-MDT in Charing Cross. Her recent imaging from Tuesday hasn't changed. And actually their concern over bleeding risk has gone down substantially. And they felt if she needed surgery, from our point of view, we should just go ahead. So we were going to repeat the CTA brain on Tuesday and transthoracic echo. And we'll come back.
She's responding to
She is.
antibiotics.
I think she is.
From my point of view, the longer we wait, the better.
Yeah. But if things change on Tuesday and it looks worse, then we just regroup.
Perfect. Good team approach to the problem.
Good.
There are so many consultants involved with decision, but eventually there will be one name next to her bed that is the name of the surgeon who operates on her. And if the things go well, it will be a great team effort. If things don't go well, obviously the surgeon will be the first name to be on the spot.
You are a popular young woman. So, we have talked and talked and talked. You have several small aneurysms in your brain. These aneurysms are caused by infected material breaking off, going up to the brain, and it burrows through the wall of the artery. So I don't think we know yet when to operate. I don't think we can decide now, but know this, we're not going to put you through surgery, that's going to cause you risk if we don't have to. Yeah.
I'm just worried with leaving it that I don't want any more aneurysms, especially in my brain.
But no new ones have formed. Remember that.
Okay. So it's just a waiting game in a way.
Yeah.
Look at the sky, the blue. You won't see that blue very long. So as you got the blue, might as well enjoy it.
70-year-old retired railway worker Chotalal is waiting for an angioplasty after arriving at the hack complaining of chest pains.
My dad's he had a heart attack in January. Over the weekend, he was just having a few pains, and again, he wasn't saying exactly what was going on, because he was saying before it was indigestion, and it wasn't indigestion, it was actually having a heart attack. So, you just don't know when it comes to the heart, and men especially don't like to admit that they might be dying, possibly, yeah.
When did you come in here? Yesterday. I came on the Tuesday, and I've been kept a prisoner since then.
So this lady is a career PCI to come to mind. This chap
is the chap on hack. We've had a very busy night. We've got lots of inpatients that need procedures. We've got a busy elective list. And we are going to get more admissions, and we are going to get more primaries. Right, Ozan, so what have we got now next?
So it is our
Primary. So can we go through this case? So, 70-year-old came in as a primary call, hypertensive, hypercholesterolemia, just one stent. It was rotablated, huh? It was heavily calcified.
He's under the care of consultant cardiologist Garda Mikhail.
So we need to check the LAD first, don't we? He has got ongoing chest pain and he's got some disease left in the other artery, so that's what we're going to treat. What we are seeing is increasingly patients with more complex coronary disease. So when I started training, we had what we call type A lesions, very simple coronary disease. You put a balloon and a stent. Now patients are living longer, they're getting older, the disease is more complex. Their arteries are calcified and hardened, which can make angioplasty more complex.
That gets given to us incorrectly.
Yeah. I got a call from LAS about a gentleman when he's arrested in the community. Downtime is 5 minutes. So at the moment, he's on his way. They're going to put a call out shortly.
So, you know what? We can't start this case now.
He's nearby, so it shouldn't be too
let's
long.
talk to him. Let's talk to him. Okay. Hello. How are you? Okay. Listen, I don't have very good news at the moment. We were about to start your procedure, but we've just had an emergency call, all right, of a patient who's really unwell. Okay, we just need to get the other patient done. I'm really sorry about that.
It doesn't matter, I got 10 years to go.
Fantastic. Thank you so much. Okay, there's a cardiac arrest coming in. We really don't like to do that type of thing, but the other cath labs are being used. This is a patient coming in a cardiac arrest situation. He's stable, so, you know, he can afford to wait compared to the other patient.
I know, I'm really sorry about that.
Any family? Any family?
Hello. Okay, just tell us what's going on. Tell us. Okay.
Right, guys, are you ready for a handover?
Yes, please.
So,
just one sec. So if he's got an output, we should take him to the lab, yeah? Every day is unpredictable. You plan for the day, but you could have a lot of emergencies, one after the other in one day, or it could be a day where you have a couple of emergencies and manage to get all the elective cases done.
Do you expect to be seen today? I don't want to impose nothing, and I'm quite patient. Because I'm retired, what the hell I'm going to rush in for? I rushed enough for more than 50 years in the jobs I've done, so...
How are you feeling at the moment?
Oh, fine, just as good as you. It's just that the inside is not happy.
So this is another one, so it's going to be crazy today.
That is exactly how it happens. You can be poodling along, and then within sort of 10, 15 minutes, you've got 2 patients coming in.
I don't know, but I feel like I'm healthy enough to walk.
I'm going in for this major surgery, but I feel fine, and it's really weird. Like last time, I was having seizures and a few blackouts, and I was on high medication, so I was feeling like shit. But this time, I'm feeling really fine, so it doesn't feel right for me to be having surgery this morning.
It's the day of Ben's operation to remove his brain tumour.
Can we come up or? No? OK, all right.
His family is here from Huddersfield to support him.
See you in a bit.
It's just mixed emotions, you know, you're trying to be positive for him and reassure him and everything, but it's a bit surreal. You just kind of
What?
I don't know, you can't imagine it. Couldn't imagine it for myself.
Yeah. What you want is it to be you.
Yeah.
You want it to be you, not him. And that's the feeling I had. It should have been me, not him.
Now we're here today and he's having it done, he's going through it all again, and it's just...
Well, he's going to come through it and he's going to be fine. He's got loads of years ahead of him. He's still got a lot to do in life. He's still got aims.
Oh, God, yeah, always, yeah, yeah.
We've created a three-dimensional image volume of Ben. You can recognise that's Ben. These are the reference points, these little markers we put on his head, which we use as reference points to correlate this virtual image to the real Ben. You can peel away the surface and look at all the blood vessels that you need to avoid. Years ago, without this sort of equipment, it would be a lot harder. I remember the days of putting a CT scan up and marking on those lines where the tumour was on the scout image to see where it would make our craniotomy. You just hold it up and stand back and look at the image on the wall. Now look where we are now. You can see I'm pointing to this fiducial. So that machine is telling me where I'm pointing. It even shows you my probe, look. Beautiful.
During the operation, Ben could lose more of his peripheral vision. There's also a risk of loss of sensation in his left side and paralysis.
It's really that bit that we want to take out there.
Ultrasound probes will carry out live brain imaging, guiding Kevin along the 3D map of Ben's brain, helping him safely remove as much tumour as possible.
On the left-hand screen, you see the grey of the MRI, and then on the ultrasound, you can see that bright signal in the cavity. Very clear cavity. I can actually see it, and there's tumour there, look. Yeah. You can actually see it with your naked eye. Amazing. OK, so we've got to try and get that out.
That's Ben, Emma, and that's Molly. Yeah, happy-go-lucky, yeah, always wanted sort of...
bossy towards
yeah,
the other two.
bossy. Always liked to have people around him.
His main thing was musical theatre.
Yeah.
He wanted to be in the West End. Yeah, he wanted to be there.
That was his dream.
Yeah.
I just hope from today that they can do what they need to do to get all the cancer out, all the tumour, so he can move on then with his life.
Ben has agreed to be part of a research programme testing a new diagnostic tool, the iKnife, which is being pioneered at Imperial.
This is the iKnife, so you take tissue, you turn it on, and it buzzes the tissue, coagulates it. You get some smoke being produced, which then gets sucked up into this tube. And that tube then goes into that machine. It tells you what the molecular makeup of that vapour is. I'm going to get some iKnife samples here, and then at the boundary. So shall I take a iKnife sample?
As the iKnife heats and cuts the tissue, it generates so-called surgical smoke.
It's basically like a sniffer knife. It's smelling the vapour coming off of the tumour. Got something?
Healthy tissue gives off a different molecular signature to cancerous tissue. The iKnife analyses the smoke and transfers the data to its computer.
We've got a very, very early model, which is not, we don't have a huge amount of data. Usually, if you were going to have a robust database, you would want thousands, even tens of thousands of bits of information to build it on. So it's very early days.
The iKnife can already identify the margin between healthy tissue and a number of different cancers, but it's still in the training phase for brain tumours.
The thing about this is that it's bringing the lab into surgery, giving us information very quickly. Maybe possible in the future we'll have treatments that we can give locally as we're operating, rather than then have to be closed up and then wait for post-op chemotherapy, radiotherapy. We can actually start giving treatments instantly alongside surgery. And perhaps, if we're lucky, give us some answers to potential cure.
Let's see. So now you can see the tumour, and I'm just now pulling it away from more normal-looking brain. But it looks kind of greyish and potentially a little bit more aggressive than it perhaps was. So what I'm going to do is resect now.
Tumour.
Ben's tumour is sent to a lab where pathologists will determine if it's more aggressive than his original cancer. It'll be 2 weeks before he gets the results.
That tumour that was down there is all gone. Yeah? If this turns out to be slightly more aggressive, then it's the best thing we could have done. Right. Good.
I'll go check you out then, Fridge.
There was an emergency, they couldn't do it for me, so I stayed one night more. I couldn't say nothing. Somebody might be in more dire trouble, so let it, I'm okay, I wasn't bad. I wasn't feeling that bad anyway.
70-year-old Chotalal had his angioplasty cancelled yesterday due to an emergency admission. He spent the night on the busy hack ward.
Current bed state is we're nearly at full capacity at the moment. As it stands, if we have a primary come in that goes to the lab and needs to go to the coronary care unit, we don't have a bed to put them in.
How do you feel about that?
It makes me nervous. We are the primary service, so anyone having a heart attack within North West London will come here via LAS.
I've got to do this because he's on hack. Needs to be done. Yeah, no, do him.
We're going to do Bowring.
And then 2 coronaries, and then whoever takes the other one with the pacemaker, yeah?
Okay, cool.
He got admitted with chest pain, and he's been cancelled once. So he needs to be done. He wasn't on the elective list. He's come in with symptoms. So you can't cancel him again because patients can become unstable at any time.
Comfortable? All right, happy for me to carry on? Good.
This is Chotalal's second angioplasty in 3 months.
Take a gentle breath in for me, gentle breath in. So this is a very small balloon that we just going to use to inflate the narrowing.
Stents are inserted into his arteries in an attempt to prevent him having another heart attack.
And try and crack that artery open. 2, 4, 6, 8, 10. That's better, and down. Narrowing was quite resistant to cracking. A lot of chalk in it and calcium, but with a small balloon it's managed to crack it open.
How do you feel about the future of the hack with the current NHS cuts?
It's actually very frustrating and really quite depressing. As a cardiologist, you want to do more for your patients. But, you know, we're getting busier and busier day by day, actually. And the staff are extremely stretched, but we have to keep going because you can't just walk out. Fantastic. We're all done here. Okay. Good. All done. All right. You all right? A bit emotional?
The benefits of having a centralised system for heart attacks is well proven. But the NHS is cost constrained. I think what's going to happen is that the emergency services, as ever with the NHS, are going to be fantastic. What might take the hit is the elective patients. So when you're not acutely unwell, you're going to wait longer. And that is a reality of the modern NHS.
So they put 2 stents. I thought there was 1, but they put 2. So and the last time I done it, it's altogether 3 now. So I's a brand new man. I's brand new.
It feels like my life has just been put on hold.
Rosa is still waiting for major heart surgery to remove infected tissue from her mitral valve. But her brain aneurysms need to heal before it's safe to operate.
If I think about it too much, I'll just be like scared and miserable.
I think that's been one of the hardest things for her, that she looks around the ward and most people on the ward are kind of 60s, 70s, 80s, and that causes you to think a bit more, why me? I think.
Yeah, I think the injustice of it all has got to her a bit.
Hi.
Amrish, hi.
Hi, Susan.
So, Rosa, the last time we spoke at the Neuro MDT, we were down to one with a whiff of a second.
Correct. So there's just
a hint.
Only because you know
Yeah.
that there was something there. Had I
Yeah.
not known, if I didn't have any of these, I would have
Yeah.
called this completely fine.
Oh.
And the right frontal one is really inconspicuous, actually, at this stage.
That is just
And I
great
don't believe that there are any other new lesions or septic foci, which I can't see on here.
This is a great result, isn't it?
Yeah.
Thanks very much.
No problems.
All
Thank
right.
you.
Well, a lot happier. I mean, even to me, I'm a cardiologist, I can't read brain scans, but even I can see that that looks a lot better. Hello. Hi. We had a look at your brain scan. Yeah. And the brain scan looks a lot better. In fact, if you weren't looking for it, you probably wouldn't even see it. This is a good outcome. It doesn't mean the risk of bleeding is zero.
Yeah.
But I think it's as low as we're going to get. So there's a window here, Rosa, and I think we're in it.
Yeah.
But she's in good hands.
Yes.
Oh, yeah.
Yeah.
Thank you.
I hope I'll get some sleep. I don't know if I will.
Hi there.
Hello.
How you doing? You okay?
Yeah.
Relief? Relief it's all over? Yeah. Feeling okay?
I'm just relieved that my vision is here.
Good. Still got your vision, yeah.
I was very worried that I would wake up with no vision or less vision, or
Yeah.
I just had nightmares that I would work it up to, or not wake up, or have blackness, or
Yeah.
If I'm honest.
It's a big relief,
Sorry,
isn't it?
I don't really know what to say.
Don't worry, just... You're going to have a bad headache because we took some pressure off, so it's going to be like the worst hangover you've had. No,
Very difficult.
Of course it would, no.
to cope with.
No, you've done really well. You know, you could almost see the tumour with the naked eye, but we just confirmed it with everything, and it all correlated, and it's all gone, so...
Oh,
yeah.
what?
Yeah, it's all
You've
good.
got it all out?
Yeah, pretty much.
Oh, wow.
Yeah. Very happy. Okay, so you can relax now.
Thank you.
You can relax.
Thank you very much.
Okay.
Wow.
All right.
Thank you. Thank you very, 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 very much.
No problem. I'll see you later.
If anyone wants to ask what relief feels like, get into my body now.
Okay, you're going to have to go back to the next operation now.
Thank you. Good
Okay.
luck.
See you.
Thank
Cheers.
you. Well
Bye.
done. Thank you.
He's had all that technology thrown at him, and he's come out the other side really well. So he will benefit, but the real benefit will come for patients in the future when that technology is really well developed and validated. But without patients like Ben, who are willing to donate their tumour for analysis, we're not going to make those steps forward.
This morning, we have got a big case. This young lady, Rosa.
You take care, my people.
You're all right.
Up until now, she's been incredibly lucky, really, health-wise, and in every regard. She's very lucky to have landed in this hospital with the right expertise. I mean, we can't thank them enough.
They've been brilliant.
Knife, please. So we make an incision, then we go underneath the breast and we enter the chest in the fourth intercostal space.
Roberto is one of the only heart surgeons in the country who performs this operation using a minimally invasive technique without breaking the breastbone.
A traditional incision would be from here, the end of the bone, to the beginning of the bone, so we'll cover all this and we'll spread apart and then open it like this. Only the noise makes me feel a little bit uneasy. It looks like a Spanish Inquisition sort of tool. I'm opening the pericardium, which is the sac around the heart. You know, this is the heart. The pericardium, the heart, yeah?
In order to operate on her mitral valve, Rosa's heart must be stopped.
You're happy there?
Yep, you've got good line pressure.
First, her blood is diverted through a bypass machine that takes over the work of her heart and lungs.
On full flow.
Yep, that's full flow there.
Next, a solution of potassium slows, then finally stops Rosa's heart.
Once it's stopped, the ECG will be flat. We can work safely for an hour. Okay, now I'm going to open the left atrium. You see there is a lot of blood here.
Within minutes, Rosa's heart valve is exposed.
It's not just a vegetation, but there is a perforation in the valve. Can you see the hole where I'm putting my instrument? But most of all, it's not just a hole. All the valve here is so thin with infection, it has to come out. We can't compromise on this. Okay, one bit is coming off on its own. At the moment, I just took out the infected part of the valve, so I think that the amount of valve tissue left is still good enough with some work for us to fix it. It's really the best scenario. Until I saw the valve, I didn't know we were going to be able to do it. Can I have some water to test it? In a patient like Rosa, who could have a life expectancy of many, many decades, so it's a long-term result. Suction. Now we've got a pretty happy valve. Can you see this, what we call the smiley face? Yeah? Once I'm out of here and we finish, closing this incision will take 5 minutes. So these minimal invasive techniques, they're proven to let the patient recover much faster. They are likely to be in hospital possibly 2 days less than the normal traditional operation. So we're saving a lot of taxpayer money. Now turn the red on, gently.
With her valve repaired, Rosa's heart is restarted.
Flow back up.
Now let's have the pacing. The heart has been still for an hour, so it's regaining its own rhythm, which is becoming better and better. Now it's sinus. Rosa's got a normal heart rhythm. The valve is looking very good. There is no leak. As far as I'm concerned, there's been a success. Hello. Hi. Good afternoon. Hi again. You remember me? Yeah?
Yeah.
Hello.
Of course.
Yeah. So all good. All good. Everything has been really straightforward. Good news that it's working well, and it's her own valve. The heart is working on its own without any support. So of all scenarios, this is really the best scenario.
Thank you so much.
You're very welcome. But we just had to wait until she wakes up and then assess her.
I'm really worried. Where is it possibly coming from?
I've spoken to the intensive care last night, but I haven't seen her since, so she's here behind these curtains. Look at her. Doesn't look like she went through much, eh?
Youth, isn't it? It's wonderful.
Morning.
You. Hard to believe you had heart surgery yesterday. So
it went well.
Yes, absolutely. All perfect. All perfect. So the valve looked like infected, and it looked like a several weeks infection. And it managed to produce a hole in the leaflet of the valve. So all that hair has been taken out, and we managed to stitch it back in a normal position. So we checked with the tube inside, and the valve looked absolutely perfect.
So my own valve.
You have got your own valve. I think this is really the best scenario.
Am I going to have it replaced in 10 years? Probably not.
With your valve working well now, we don't know. We just have to check over the time. Obviously, we need to hope that the infection is gone completely.
Yeah.
Good. You're happy?
Very,
Well,
happy. Thank you.
I'm very happy
I'm
too.
really delighted.
This is just the best outcome we could have hoped for, yeah.
Yeah, really happy. Thank you all so much. Just
Great.
in awe of your work.
No, not at all, Rosa. It's a pleasure.
Top job. All right. All the best, yeah. Bye-bye.
Great. Made my mom. Made my year. See you later.
Thank you card doesn't really cover it, does it? So yeah, and I'm really happy.
I'd give you a hug, but it would probably be unprofessional. It's fantastic.
We're all very pleased.
There has been a drive in the NHS, and I think it's been the right one, to concentrate services in specialist areas. I think Imperial is probably unique in that it's such a large cardiac unit, but also has a very large neurology, acute stroke unit, neurosurgical unit, so you have this confluence of expertise, which actually, when it came to Rosa's case, was absolutely appropriate.
This has been a long time coming.
These has, you've been brilliant.
Yeah.
Okay.
So it looks as though we've got a primary angioplasty that's just arrived. Anterior hyperkinesia.
Yes.
Okay.
Anterior ST elevation and...
Okay. Don't worry about him. He's having a heart attack, but we'll get him in straight away and we'll get him sorted out. Don't worry about him. You take a seat in the waiting room and we'll get him sorted out quickly. He'll wait, okay, and we'll come out and let you know. Thank you.